Girish sir. രണ്ടാളെയും വിളിച്ചു.
തുടങ്ങാല്ലേ മാഡം?
തുടങ്ങാം. Okay. Start.
Good evening, everyone. A warm welcome to the much-awaited Kfog Ed series conducted by the Adolescent Committee of Kfog. We'll start with a silent prayer. To deliver the welcome address, I invite Dr. Mini Balakrishnan, Chairperson, Adolescent Committee of Kfog. Welcome you, madam.
So good evening and welcome to the Kfog Ed's webinar series, which is conducted in association with KANNUR, KASARAGOD, CALICUT, WAYANAD and PERINTHALMANNA Society. So today the topic is adolescent PCO, which is the most prevalent problem among the adolescent, and the right topic to discuss, as well as the right time to intervene at this age. So I am very much thankful to our president, Dr. Kunju Moideen sir, who has had this novel idea of updating the members through the Kfog webinar series. Warm welcome to Kunju Moideen sir for taking up such an initiative. Our chief guest today, Dr. Neena Malhotra, who is the professor and HOD of AMS Delhi, has readily consented to grace the occasion. Welcome to you, ma'am. Our experts today, Dr. Girish Mani and Dr. Bharati Rajashekar. Welcome you both. Girish sir was the past chairperson of Foxy Adolescent Committee and has got a passion for adolescent health in his mind. Excuse me, Dr. Bhavya, Girish Maniക്ക് ഒന്ന് ലിങ്ക് അയച്ചു കൊടുക്കും. Both Girish Mani sir and Neena madam, both are calling me. So then Dr. Also he has done several projects on adolescent health. Last year he was the adolescent health chairperson. So welcome you, sir. Also welcoming our expert today, Dr. Bharati Rajashekar, Bharati madam, another expert in the very much who is very active in academic as well as organizational activities as far as her CV shows, and she will be introduced in a great manner soon. Dr. Sujitra Sudhir is the past vice president and president-elect of our Kerala State Federation and the coordinator of Adolescent Ed series. And she runs a show in a very elegant, systematic, and attractive way. Welcome you, ma'am.
Thank you.
Our state secretary, Dr. Subhash Manya, he is the backbone of our society, and he gives all the technical support in spite of his busy schedule. Welcome you, sir. All the society presidents, Dr. Vidya Nambia, Dr. Geeta Meko, Dr. Omana madam, Dr. Lakshmi, Dr. Kochuman, also all have all joined, and they are always being promoting us, and they have readily agreed to give their representatives and speakers from the concerned societies. Welcome you all. And today's eminent panelists and speakers, Dr. Ashwati Kumaran, Dr. Jayalakshmi Suresh, Dr. Suma Vishnu, Dr. Smita Srinivasan, and Dr. Shaijas. All the best for them. I'm sure you all will do well, and this is going to be a very interesting and useful CME for you, for all of us, and let them have a great day today. Also welcoming Dr. Bhavya Saran, who is the MOC for today. Over to Bhavya to run the show, and all the best to all of you.
So we'll begin the program. So in the absence of our dear Kunju Moideen sir, we'll move on to introducing our chief guest for the day. So the chief guest for the day is none other than Dr. Neena Malhotra, Professor and HOD, AIMS, New Delhi. Madam has a teaching experience of over 30 years, and her area of interest is reproductive medicine and infertility, endoscopy, and high-risk obstetrics. She has innumerable number of awards and fellowships on her name, and she has won a number of awards like Ethicon Traveling Fellowship, Foxy Imaging Science Award, Foxy CS Dawn Award twice, and Foxy Corion Research Award, and Professor Ratnabai More Oration by Karnataka Society. And she also held many positions in Foxy, like member of Fetal Medicine Committee, member of Managing Committee of AOGD from 2007 to 8, member of Managing Committee of AOGD from 2019 to 20, and executive member from 24 to 25. And she was the secretary of General Indian Fertility Society from 2020 to 2022, senior vice president of Indian Fertility Society from 22 to 24, president-elect of Indian Fertility Society from 24 to 26. And Madam is an invited speaker at various national and international forums, delivered over 300 lectures. And Madam is also a principal investigator for many research programs, and also has published around 138 articles in peer-reviewed journals and 24 chapters in national and international books. So I welcome Madam for the inauguration and giving the chief guest address.
Okay, I think Madam is yet to join. Madam was asking for the link while I was speaking. I don't know.
I've sent the link actually.
Okay. I also have just sent it. It takes little time. Let us wait. Madam can send the link to Suma also. Suma is also asking.
Madam, in the meantime,
Yes.
Can we start with the first talk, madam?
She will join, madam. She will join.
No, we'll first then. Madam, join Cheta. Bhavya, Madam, join Cheta. Girish sir has joined. Subhash, can you send the link to Nina Madam or just call her?
Okay, madam. Yes, ma'am.
Madam, shall we begin with the felicitations?
Ma'am is asking, let me. Okay, but start the felicitation then.
So we have our dear Sujitra Madam, who's the Kfog President-elect and also the chairperson for the Kfog Edge webinar series. So I welcome you, Madam, for the felicitation.
Thank you, Bhavya. Can you hear me?
Yeah.
Actually, it is with a sense of immense pleasure that we are witnessing the 8th Kfog Edge seminar. This Kfog Edge seminar has kept us all on the edge of our chairs because so many new topics have been coming up. It is a wonderful idea of our president, Dr. Kunjumoideen, and it has been beautifully carried out by the various chairpersons. And I congratulate Dr. Mini for taking up this challenge and making this PCOS a very interesting panel with a lot of experts and speakers. So we are very happy that today we are having this program and we have Dr. Subhash Malya with us, our chief guest, Dr. Neena Malhotra, who is very well known, and Dr. Bharti Rajshekar, Dr. Girish Mane as the experts, and all our North Malabar societies, that is KASARAGOD, KANNUR, KOZHIKODE, WAYANAD, and PERINTHALMANNA. So all the presidents are there. So I won't take up much of your time. Let the seminar begin and let us have a good interaction, because PCOS is said to be the Pandora's box with never-ending problems, no complete cure, and it has so many facets to it. So thank you for this opportunity and congratulations to all of you.
Thank you, madam. So we have, I invite Dr. Vidya Nambyar, the president of KASARAGOD Obstetrics and Gynecological Society, for the felicitation. Madam. We'll move on to Dr. Geeta Mekut, the president of KANNUR Obstetrics and Gynecological Society, for the felicitation.
Good evening to all the esteemed guests on this platform. Thank you, Dr. Kunju Maideen, for the novel Idea for Edge program, which is so beneficial to all those involved. This is actually a very focused, good platform for many of us in the review of so many topics. It also bonds so many societies who are far away. Thanks to Sujitra Madam, the coordinator, and Dr. Mini Balakrishnan, the chairperson of Adolescent Committee, Kfog, for your hard work in making this webinar fruitful. PCOS being a lifestyle disease, we have to work towards improving the metabolic health of our patients, thereby preventing so many lifestyle diseases and cancers. Wish the whole team of Kfog all success in the future webinars.
Thank you, madam. I would like to call upon Dr. Omana Madam, President of WAYANAD Obstetrics and Gynecological Society, for the felicitation.
So, most respected our Kfog President, Dr. Kunju Maideen, Secretary Subhash, our State Coordinator, Kfog Edge, Dr. Sujitra, and the most hardworking person, I should say, in Adolescent Committee Chairperson, Kfog, Dr. Mini Balakrishnan, our Chief Guest, our distinguished faculties and friends who are attending the Kfog Edge Webinar Series 8 on adolescent PCOS. I think we never thought there are so many things to discuss regarding PCOS. Today's topic is, you will see complications in diagnosis, menstrual problems, psychological issues, very, very important, insulin sensitizing therapies, long-term management, and lifestyle interventions. I think these small things are taken care of in Kfog Edge webinar regarding PCOS, and we understand that there are so many things we can study and we can know from this webinar. So, wishing all the best for today's webinar, and thanking you all for making me and our society a part of this webinar. I wish all the best for today's webinar. I'm sure we will have so many take-home practical points after today's webinar. Thank you.
Thank you, madam. Now I call upon Dr. Lakshmi, the president of CALICUT Obstetrics and Gynecological Society, for felicitating the gathering.
Esteemed faculty and viewers, a very good evening to one and all. As already mentioned, the Kfog Edge series is already into its 8th episode, and this being the brainchild of Dr. Kunju Maideen, has already proved that it is a class apart, mainly because of the selection of its topics and faculty. And I consider it a great honor for a society to be associated in co-hosting this webinar along with the other member societies. Looking forward to excellent deliberations in the future episodes also. I wish this program all success. Thank you.
Thank you, madam. So we have none other than our Dr. Neena Malhotra joining us as our chief guest. Welcome you, madam. Welcome you for the inaugural address.
Very good evening. And I think at the outset, I'm humbled to share a platform with such brilliant people. Dr. Kunju Maideen, Dr. Subhash Malaya, the two geniuses from God's own country, as I put them. I feel really humbled because this is not the first time. They have called me many times and I've really enjoyed this series. So to begin with, my reverences and respect to Dr. Bharti, Dr. Avasti, Dr. Bhavya, Dr. Geeta, Dr. Girish Mane, Dr. Jaya Lakshmi, Dr. Kochu, Dr. Lakshmi, Dr. Mini, Dr. Omna, Dr. Saijus, Dr. Smitha, and Dr. Vidya. I hope I have not missed any names. If I am, I would really sort of beg pardon. I think whenever I have come, be it for the infertility or any other, I have gone back so enlightened because these are the kind of platforms where we know we're reading from books. We have journals, but the true insight when we sit on a panel is different, because each individual is different. We know PCOS is a plethora. A PCOS from the Northeast will not be similar to a PCOS from Kerala. After having done the ICMR trial where we looked at prevalence, we found that this was a disease which is different in different continents. And I think Indian PCOS may not really fit into be the Rotterdam or the newer classifications, be it on our PCOM morphology and also on our symptoms. And I thought when we put this data, and we published a lot of papers from this, where I know Trivandrum was one of the sites for, we realized that what we missed in this whole entire effort was we did not take in this phase 1 adolescent. And I think we've put in our phase 2 where adolescents are a part of our now ongoing study. And I think we will get more wiser to learn how PCOS adolescent in India behave different from those. So I think this is the best platform where some of the burning topics and issues will come, which we will take and put it to the ICMR when we go for a phase 2, brainstorming. And I'm really happy to be here. Once again, congratulations to be, taking this way forward. And I also have a humble request. I'm taking my elections for the post of a chairperson for the imaging science. And I take this opportunity to really, have my gratitude to the societies who have actually nominated me from Kerala, a lot of you. And also I will look forward to your support when the election links come. So thank you very much once again. And I wish you all the best for this brilliant academic, feast that is lined up in the next 1.5 hours. Thank you very much.
Thank you so much, madam. Now I call upon Dr. Subhash Malya for rendering the vote of thanks for this inauguration ceremony.
Thank you, very respected President Dr. Kunjumoideen sir, President-elect Dr. Our chief guest for the evening, Dr. Neena Malhotra, Professor Neena Malhotra, madam. Chief guest of honor, Dr. Girish Mane, Dr. Bharti Rashik, and all the senior members of all the societies and all the president secretaries of all the 5 societies. I would like to thank you for your wonderful work that you have done in this year till the 7 8 series, and we're looking forward for all the support from you in future also. And like thank you all of you for a positive time. I would just like to keep very short. Thank you. Thanks a lot. Thanks.
Unmute Maya. Unmute. Bhavya, unmute.
Hope my screen is visible.
Yeah.
So we'll begin with the academic session. We have 2 great personalities as experts for today's session, Dr. Girish Mane and Dr. Bharti Rashik. Excuse me. So introducing Dr. Girish Mane. Sir was the past chairperson of Adolescent Gynecology Committee, AMOX, from 2022 to 24, past president of Yavatmal OB-GYN Society, vice president of ISOPAP Vidarbha chapter, winner of various awards, Foxy Champion Award in 2019, and he has been awarded by Governor of Maharashtra for exemplary work done in COVID pandemic. And sir is the recipient of Foxy Smriti Mailan Save Baby Girl Runner-Up Award, recipient of Durusha Youth Trophy Award, and Dr. Sadhana Desai Award, and many other in his list. Sir has contributed many chapters in Foxy Focus, and sir is the editor of Foxy Focus, Adolescent Intervention for Future Reproductive Health. Welcome,
was the
sir.
Foxy
Foxy
chairperson last year also. And for the last talk also we had invited, but unfortunately he could not come. So welcome you, sir, for this. That's why we called you again.
And madam, we won the best chairperson award last year. I mean, Adolescent Health Committee bagged that award last year.
Yeah, I know. We just missed.
Thank you.
Welcome you, sir. We also have Dr. Bharti Rashik, the president-elect of KSOGA 2324. Madam is also the director of Hassan Indian Red Cross and KPMEA state vice president. Madam has a vast experience as IMA state past vice president, and Hassan OB-GYN Society past secretary, and a PCPNDT committee member. And Madam has organized many conferences, and Madam is also a winner of various awards, like President Medal for Topper and Final MBBS in Madras University, Foxy President Rotating Trophy as Secretary, and Dr. D.K. Tang Award, and Madam is also a faculty in various state and national conferences. Bharti Madam is actively involved in adolescent health awareness activities and conducts first aid and basic life support workshops for public drivers in colleges. Also, Madam has won the President Rotating Trophy as President of HSOG, and also a long list of experiences like cancer screening camps and HPV vaccination camps. And Madam is also having special interest in non-communicable diseases, in adolescent health, family welfare, and contraception. Welcome you, Madam, to this webinar.
Thank you, Dr. Bhavya, and I thank all the Kfog, Dr. Kunjumoyedeen sir and Dr. Subhash Mallya for giving me an opportunity to be here today.
Now we'll move on to the first topic of the day. The first topic will be dealt by Dr. Ashwathi Kumaran from Malappuram. The topic is complexities in diagnosis of adolescent PCOS. To introduce Dr. Ashwathi, Madam is a senior consultant and head of reproductive medicine, Aster Miracle Fertility and IVF Center, Aster MIMS Kottakkal. And Madam has special interest in reproductive endocrinology, and she has an experience of more than 17 years. Ashwathi Madam is an invited faculty in national and international conferences, authored many articles in index journals and many chapters. And she is the first FNB Reproductive Medicine Fellowship from Maulana Azad Medical College, Teaching Excellence Awardee from Kasturba Medical College, Manipal, and have won many gold medals in state and national level, IFS Achiever Award of 2022, and also is a PERINTHALMANNA OBG Society Executive Committee member. Welcome you, Madam, for the talk.
Thank you, Bhavya. Thank you, all the eminent seniors, Neena Madam, Bharti Madam, Sir, for gracing the occasion. Am I audible?
Yes, yes.
Yes.
Yes,
Shall-
yes, yes, madam.
So I'll just go ahead with the topic. I would like to share my presentation. 1 minute. Good evening. Is my slide visible?
Yes,
Am I
yes,
audible?
Ashwathi.
Is the slide
Yes.
visible?
Yes, yes, madam.
Complexities in diagnosis of adolescent polycystic ovarian syndrome.
Thank you, everyone. Glad to be here as part of the K4G series. So the topic for we are having we are having a presentation on adolescent PCOS, and we are starting off with the diagnosis. So I'll be talking on the complexities and the diagnosis of adolescent PCOS.
Okay. Jayalakshmi, madam, please mute.
Dr. Jayalakshmi, please mute yourself. Dr. Jayalakshmi.
Okay, please.
Dr. Jayalakshmi, please mute yourself.
PCOS, as we all know, is a lifestyle disease, a metabolic problem, an endocrinopathy that stays with a woman who is diagnosed lifelong and often causes a lot of morbidity in her health as well as in her psyche. So knowing about it, diagnosing it correctly and managing is very important. There have been a lot of opinions and lots of guidelines that have paved way to what is the latest. And I am using the recommendations mentioned in the International Evidence-Based Guideline for the Assessment and Management of Polycystic Ovarian Syndrome that came out in 2023. That is a consensus of the evidence-based recommendations that have been put forward by many societies. Almost 36 societies have come together and put forward this recommendation. So it is based on this that I am putting forward my talk. So as we all know, PCOS diagnosis is based on the revised consensus Rotterdam criteria, which requires a woman to have irregular periods or oligo or anovulation that is documented, and hyperandrogenism. These are the two features when other causes are excluded leads to the diagnosis of polycystic ovarian syndrome. But we see some women who don't have both of these criteria together, but have either irregular cycles only and hyperandrogenism, and all the other endocrinopathies like thyroid, prolactin, other causes have been ruled out. In them, PCOS is diagnosed if these ladies have polycystic ovarian morphology on ultrasound or increased AMH. AMH is a new contender into the diagnosis. It has been introduced into the guidelines now. So if a woman is having irregular periods and PCOM on ultrasound, any two out of these three criteria, she can be diagnosed as having PCOS in adulthood, provided the other causes have been excluded. So this is for adults. It is more or less straight out. So many consensus have paid way to this one. So it is irregular oligoanovulation proven and hyperandrogenism. Other causes ruled out, it is PCOS. If either of the two are only present and if there is PCOM or increased AMH, then it is again PCOM in adults. The other causes, this is just for the, because I am going into diagnosis, this is just so that we know about what other things we have to rule out before we label a woman with the diagnosis of PCOM. We have to rule out thyroid dysfunction, congenital adrenal hyperplasia, hyperprolactinemia, other causes of androgen excess, whether it is neoplasm or Cushing syndrome, which causes steroid excess again. Or often what happens is, especially in adolescents, PCOM misdiagnosis suppresses the diagnosis, or misdiagnosis of PCOS masks the actual ovarian insufficiency that the patient is having. So all these things have to be ruled out before we go into for a diagnosis of PCOM. Adolescence is generally considered as the growing up period between 10 and 19 years where reproductive maturity is reached. And in the gynecological aspect, in a girl who has achieved menarche, reproductive maturity is generally reached 8 years post-menarche. So this is the period that is considered as part of adolescence, and it has been noted that PCOS is seen in 3.4 to 19% of adolescent girls. So it is under 20% that the true presence of PCOS is there in adolescents. Adolescent PCOS diagnosis is quite confusing, and when we misdiagnose accidentally a child without PCOS as having PCOS, often it changes her entire psyche. Often PCOS is a condition that is associated with a lot of stigma, especially in the educated women and girls. And many people are frantic when they are given a diagnosis of PCOS. Of course, if someone is having PCOS, knowing that they are having it and adjusting their lifestyle, and their doctors being aware of the condition so that they can coordinate their life manage for them is very important. But giving a false diagnosis can really affect a person's psyche very badly. I think the psychological aspects of PCOS and misdiagnosis, all that is being dealt with in another talk today. So in adolescent PCOS, there is often confusion because the diagnosis is based mainly on the irregularity of the periods and on the presence of hyperandrogenism, both of which may be transiently normally seen in adolescents. Irregular periods during the first period post-menarche is quite normal. So if it is causing a healthy issue for the girl, we treat that, but we should not call her PCO unless that first year following menarche has passed. The other thing is, the first thing that a girl with irregular periods, when they approach a doctor, one of the first investigations that are done is ultrasound. These are young girls with good ovarian reserve, and the multifollicular ovarian picture that is seen on the ultrasound usually leads to the misdiagnosis of polycystic ovarian morphology, and straight cut, the girl is labeled as PCOS just based on the higher number of follicles that is normal in the adolescent girl. The other thing is clinical hyperandrogenism features that are used for the diagnosis, that clinches the diagnosis when present along with ovulatory dysfunction in adults, is often quite inaccurate in the adolescent. Acne, often transitory, is very common. It needn't be a marker of clinical hyperandrogenism. Alopecia, also not accurate in adolescents, and hirsutism, unless it is very severe and progressive, should not be used for a diagnosis of PCOS in adolescents, because hypertrichosis, especially in southern India, hypertrichosis, transient like acne, is often part of the hormonal reproductive maturation in adolescents. And the other thing is some girls with irregular cycles in whom clinical hyperandrogenism is absent and who are actually having PCOS, their diagnosis is missed because biochemical hyperandrogenism is not picked out. So overdiagnosis and underdiagnosis both can be problems in adolescent PCOS, in girls with periods irregularity in adolescence. Hence, in adolescents, what the consensus says is to diagnose PCOS, the girl should have irregular cycle or proven oligoanovulation and hyperandrogenism. Both these are the only relevant criteria, with, of course, the exclusion of other causes. We don't want a girl with primary insufficiency to be managed for years as PCO and then coming to us with zero reserve and undernourished status, thinking that she is obese PCO. So in adolescent, PCOS should be diagnosed based on documented oligoanovulation and hyperandrogenism, with, of course, the exclusion of other causes. But some girls, even when the other causes are excluded, do not fit into any particular diagnosis. These girls will either have irregular cycles or hypoandrogenic features. So if only one criteria is present and other causes for her complaints are ruled out, she is considered at risk for PCOS, and a definite diagnosis for what the problem is for her is to be done by reassessment at reproductive maturity. Biochemical hyperandrogenism needs to be ruled out before saying PCO is not there in an adolescent. So when there is reproductive periods irregularity, all the other things are coming normal and she doesn't look clinically hyperandrogenic, it doesn't really, it might be just a normal condition, but it doesn't really mean that she is not PCO. So if the expensive biochemical evaluation we are not doing, then it is always better that she is considered at risk and reevaluated once again when she is 8 years beyond her menarche or towards her early adulthood, and then decide what her actual pathology is for her menstrual irregularity. Ultrasound and AMH not indicated, not recommended for making a diagnosis of PCOS in adolescent. This is very, very important. Whereas in the adult, the ultrasound does form a part of the criteria of the diagnosis if the other two features aren't there. Along with one of the others, if this is there, high AMH and ultrasound can definitely be used, but not for the adolescent. It is not yet there in the recommendation. Ultrasound is ruled out. AMH, we need more clarity. Coming to the diagnosis in detail, going into how we can diagnose PCOS in adolescent. So the first criteria that we need to look into is what irregular menstrual cycles are in the young girl. So in the first year post-menarche, irregular menses is quite the norm, and irregular menstruation then is not generally taken as criteria for diagnosing PCOS. If she has menstrual irregularities, we treat it, but we do not label it as PCOS. first to 3 years post-menarche. If the cycles are too frequent or delayed beyond 45 days, then that is suggestive of oligoanovulation or considered as menstrual irregularity. 3 years post-menarche, the delay beyond 35 days is considered as a suggestive of oligo-ovulation or delayed ovulation or cycles that are frequent or infrequent cycles per year. And more than 1 year post-menarche, if there has been amenorrhea of 3 months or more, even that is suggestive of anovulation. Also, the other menstrual irregularity that might be seen in the adolescent is not reaching menarche post breast development by 15 years. So if that doesn't occur, these girls should also be evaluated whether they are PCO or whether they are insufficiency or they are having central causes or other causes for their primary amenorrhea. Primary amenorrhea PCO might be easily missed. We have to keep this in mind. The other practice point from the guideline is that even when girls or women are having regular menstrual cycle, they still might be having anovulation. So if they are having the other features, all the other hormonal pathologies and other diseases are excluded. And if they are having features of hyperandrogenism, clinical or biochemical, just because they are having regular cycles, we should not rule out, we should not say that they are not having PCOS. Make sure they are either by ultrasound or by other methods like serum progesterone levels, whether they are ovulating or not. And if they are actually anovulatory cycles and they are having increased androgens, they fall again into a diagnosis of PCOS. Now, the second criteria, hyperandrogenism, clinical hyperandrogenism. As I mentioned earlier, acne and hirsutism may be transiently seen in the growing girl. So unless the acne is no longer universally accepted as a clinical hyperandrogenic criteria for the young adolescent, unless it is very, very severe, and progressive severe hirsutism only should be definitely considered as a marker for clinical hyperandrogenism for the young girl. Alopecia does not have much relevance. So in the adolescents, it is severe acne and hirsutism that will help label her as having clinical hyperandrogenism. We can use a scoring system like Herman-Galway, or we can see the thickness of the hair. It is the terminal hair that we need to assess while assessing for the hirsutism. And as I told earlier, in case we are not really sure whether the girl is having hyperandrogenism, because to reach a diagnosis of PCOS in the adolescent, along with her irregular cycles, she needs to have proven hyperandrogenism. So when we are not really sure about her clinical hyperandrogenism, unless the biochemical hyperandrogenism is present, we can't diagnose her as PCOS. If we are not doing the test, we consider her at risk and then we reassess to see whether she is PCOS or not. So the androgens that are to be tested are total testosterone, free testosterone assessed by the free androgen index. And if these two are coming normal, DHEAS and androstenedione need to be ruled out, and the tests have to be really accurate for the pathology to be picked up. And of course, PCOS, we need the exclusion of other causes. Other causes for hyperandrogenism, hypothyroidism, hyperprolactinemia, central causes, iatrogenic causes, syndromes of insulin resistance, all these need to be ruled out. So we covered the 3 criteria that are required for adolescent PCOS diagnosis: confirmed oligoanovulation or irregular periods, along with hyperandrogenism and the exclusion of causes. And in these girls, as part of the preliminary testing, it is mandatory or it is very important to do glycemic testing, because nearly half of them will have problems, and their management definitely depends on, and how they need to modify their lifestyle depends on how much insulin resistance they are having. 75-gram oral glucose tolerance test is considered the most accurate. And in the adolescents, if this is not feasible, glycated hemoglobin or FBS can be used, but the diagnostic accuracy is significantly reduced. Insulin assays are not recommended, and the presence of acanthosis is a marker for insulin resistance. As I mentioned earlier, do not use ultrasound to form a diagnosis of PCOS in the adolescent. What we see time and again as practice is young girls and young mothers coming frantic with an ultrasound report saying that they are having PCOD, PCOM, PCOS on the scan. Most of them are quite unaware. They are scared for their lives. And all that frantic stress and problems often can cause metabolic disease later on. So when we are giving out the ultrasound reports in young girls, multifollicular appearance is quite normal. So do not mention PCOM in the adolescent. There is specific diagnostic criteria for polycystic ovarian morphology on the ultrasound, which should be used when we are giving out reports in the adults. There should be a consensus among radiologists and gynecologists so that in adolescents with sufficient ovarian reserve, not to give out the ultrasound picture of PCOM. And serum AMH, according to the guidelines, should not yet be used in adolescents. We can, of course, use it to find out how we are going to manage the patients or to know whether we are actually missing something, even though the pictures are all suggest. This is all, but according to the guidelines, we are not supposed to use AMH for the diagnosis, unlike in adults. And what about the adolescents at risk? I had told earlier that those with oligoanovulation features only or hyperandrogenism only, they are considered at risk. These girls need to be reassessed later. First, 3 years post-menarche and then 8 years post-menarche with an ultrasound to see whether they are having PCOS or not. Then their 8 years post-menarche, at the end of their adolescence, when they are having oligoanovulation, ruling out of other causes, and the scan is showing polycystic ovarian morphology, not multifollicular appearance, then they can be labeled as PCOS. And in primary amenorrhea girls, rule out the other causes like ovarian insufficiency, central causes, hyperandrogenism, and with the presence of functioning ovary, that is we have to rule out that the ovary is not, she is not in ovarian failure, she is not having central hypogonadism, and a normal looking ovary with hypoandrogenism clinches the diagnosis of PCO in the adolescent. Why is PCO diagnosis accurately in the adolescents and identifying the at-risk important? Because PCOS, once diagnosed in a girl, if somebody is having PCOS, it's a lifelong disease, and the awareness, knowing the correct diagnosis helps the girl learn in how to manage and contain the problem. Other family members may be also having the disease. So if we make the diagnosis in an adolescent, we should screen ideally the others to see whether they are having the problems or not. PCOS diagnosis is important because these women are high risk for diabetes mellitus type 2, cardiovascular disease. Hence, being aware helps in maintaining a lifestyle, good healthy lifestyle, and looking out whether these problems are occurring or not. They will be aware that they can have future fertility concerns, and they will know how to address these conditions without a huge lag time. When a PCO woman becomes pregnant, automatically her pregnancy is a higher risk and requires specialized care. Depression and anxiety and eating disorders are often part and parcel of a girl suffering from PCOS, and if PCOS is managed well, these can also be managed. sleep apnea, even with normal BMI, which leads to the overall decrease in quality of life of an individual, can be there with PCOS. Endometrial hyperplasia and cancer risk, of course, is there. Hence, knowing whether a girl is having PCOS makes a big difference. So we should not miss a PCOS diagnosis, just like we should not be overdiagnosing it. So a definitive PCOS diagnosis helps to form a lifelong reproductive health plan, help them maintain a good lifestyle, maintaining optimal weight, and let them know how they can go ahead with their fertility. They can screen for diseases and keep away from them. It will enable them, empower them to seek good care during their pregnancy, and they will always be aware that if there is a significant problem, they need to go for evaluation to rule out malignancy. And why should we not misdiagnose? Because it results in unnecessary treatments. It worsens the psychological distress, and hence premature diagnosis of girls at risk as PCOS should not be done. So the take-home messages are irregular cycles and hyperandrogenism both are needed for the diagnosis of adolescent PCOS. So do not use ultrasound and AMH to diagnose adolescent PCOS. Avoid misdiagnosis based on just the ultrasound picture or the increased AMH or transitory clinical hyperandrogenism features that can be seen in adolescents. Identifying the girls at risk and reassessing later to confirm or ruling out PCOS is very important. Accurately diagnosing PCOS adolescent is important so that they lead a healthy life and can seek out appropriate management for their metabolic disorder. Thank you.
Thank you, Dr. Ashwati.
Yeah, very nice and very elaborative talk by Dr. Ashwati. As such, you have covered almost everything in the complexities of the diagnosis of adolescent PCOS. But unfortunately, there are two aspects which should be really discussed on this dais. As you have already told that only two criteria, I mean hyperandrogenism, either clinical or biochemical, and anovulation, correct? These should be the criteria, and these are the criteria according to the 2018 X-ray guidelines, as everybody knows. But unfortunately, in the practice, most of the patients, they are not only overdiagnosed, but mostly misdiagnosed on the basis of USG only, because our radiologist friends and many even obstetricians, I'm specifically the people who are practicing since more than 10 years, they are giving the very rampant diagnosis of PCOS on the basis of USG. And that's why the young girls and their mothers who are trained in the Google University, they are getting little bit stress, and they are, getting panicky because of this PCOS or PCOS, what they are usually using these terminologies in the routine or in the day-to-day life. And that's why many girls, they are misdiagnosed, they are over-treated most of the times. And you said very correctly, this should be the main take-home message, that AMH and the PCOM, that is the diagnosis on the USG criteria, should never be taken or should never be given importance. And only two criteria, that is the anovulation, on the based on the history, based on the history of menstrual history of that girl or that patient, and the clinical or biochemical hyperandrogenism should be the only criteria. See what happens. Actually, I have one patient, very close girl to me. She is in Nagpur, and she had irregular menses, and she had been to one very senior gynecologist in Nagpur. And that doctor, she got her AMH done, and unfortunately, the values of the AMH, they were below 1. And that time, the discussion went on a very wrong direction, and that doctor, she convinced that girl of only 19 years, that you have very lesser AMH, you will get some problems in your fertility, so you should freeze your egg, you should retrieve your egg, you should freeze them, and so and so. And that girl and her mother, they were so, they were so disturbed. Then I sent that family to Dr. Chaitanya Shembekar. You must be knowing Dr. Chaitanya Shembekar. He's from Nagpur. Then we convinced that girl and that mother that AMH don't have any connection, and there are variations in the AMH levels also, diurnal variation, menstrual variation, and even lab to lab, the values of the AMH, they are changing. And that's why we should be very particular about, giving this doing the investigations of the patients, especially in the young girls, isn't it? And nowadays, the USG machines, they are improving so much that is given a minute, these follicles, it is picking up, and that's why there are no certain criteria. Even though many books or many studies, they are giving number like 20, 25 follicles in findings, but even personally I feel that it should never be a criteria, specifically in the diagnosis of the adolescent, and very rightly pointed out Dr. Ashwati, and thank you very much, and congratulations for your great talk. Thank you very much. Over to you, Bharti madam.
Dr. Girish Mane. And Dr. Ashwati, you have very well brought out the correct guidelines. But one thing I would like to say here is many children are being branded PCOS because of the over-enthusiastic use of imaging very early in their lives. It's just they come just now. As this webinar was going on, I had a young girl who has been delivered by me. She's around 14 years. And her mom said that around 12 months, when she was 2 years back, that is when she was around 12 to 13, she had a menstrual bleed. She went to the some doctor and the gynecologist, and they said she may have started menarche. And then later on, she didn't have any periods. And then in the past 1 year, she's been going to numerous doctors, and they have all prescribed medroxyprogesterone acetate for withdrawal bleeding for this girl. And her mother comes to me today. She's very much worried, and she's saying, doctor, I said nothing will happen. She's just 14 years today. Her breasts are well developed. Her pubic hair is well developed. I said, just wait till 16 years. Don't give her any medication. Just lifestyle modifications, some exercises, and good nutrition with proteins and calcium and iron rich food, and make her do some exercises. And this girl is in her 10th standard. They have put her in these classes which go on from 7 o'clock to 7 o'clock, 12 hours, which is a psychological stress these children are having. And what has happened, she has undergone 3 scans already. 3 scans, and they have put this girl, mother thinks that she has an ovulatory problem. So I think this imaging of girls below the age of 18 years, we should have a lot of inhibition, stop doing it and branding them. I think just maybe if they're 17 or 18 and they have a cycle once in 3 months, I think it should be okay unless she has signs of hyperandrogenism. Then you tell them to do lifestyle modifications like exercises, cut down on the junk food, nutrition and stress. And I think that will probably prevent them from going into a full-blown PCOS later on in life. So in adolescent PCOS, because day in and day out, we are seeing girls who are 14, 15, and they've got a scan done, they have some acne, and they are branded as PCOS. I think with that cutoff line, we have to take, and we have to be a little cautious, especially when they're just 3 to 4 years post-menarche. And thank you very much, Dr. Ashwati. You have brought out the guidelines very well. And over to the next speaker.
Thank you, madam. For the next topic, we have the menstrual irregularities of puberty, psychological issues, and the talk will be rendered by Dr. Jayalakshmi Suraj, Director of Dreamflower IVF Center, and she's MBBS MS and has a diploma in gynec endoscopy. Over to you, madam.
Lakshmi is there?
Madam? Madam
She was there here.
Was there here.
Shall I call? Or we'll move on to the next speaker?
Madam, we'll move on to the next topic.
Yeah.
Madam, a small request to everyone. Can you please rename yourself? Actually, we can see only Dr. Bhavya for 5 to 6 faculties. So it's giving some.
Bhavya.
Yeah.
Bhavya, I think her mobile is also on. That's all. Suma Vishnu. Okay. Okay. Okay, now it's okay.
I think
Yes, yes. Now it's okay.
I think we'll move on to the next topic.
Yes.
The next topic would be the latest in insulin sensitizing therapies by Dr. Smita Srinivasan.
Brenda.
Madam.
Good evening, madam. I thank all of the organizers of the Kfog Edge series for this wonderful opportunity. I'll share my slides. Someone else is sharing.
Dr. Jayalakshmi's Wi-Fi is not there because there is heavy rain in that area. She will join whenever she is able to join. By the time, we'll continue with Dr. Smita.
Okay. I'm trying to share, but I don't know what's happening. Mini madam, can I send my slides to you? So
Madam,
that
send that to me, ma'am. I'll
Smita madam,
I don't know your name. And I don't know the number.
Yeah, I'll message you.
Smita madam, what message you are getting on your the screen?
1 second. This when it's opening, but it is
No, you first open
unknown.
you first open your presentation on your laptop.
Yeah, I've opened it.
Right.
But when I'm
Then
trying
start
to
sharing, screen share.
yeah,
Okay.
yeah.
Then that select your presentation and then share it.
Yeah, but it is here. It is written. Allow Zoom Workplace to share your screen and open system settings and.
Madam, I've sent you a message from my phone.
Yeah, okay. Seven 166, right?
Yeah, I got it.
You got it?
Yeah.
Accessibility. So can you please share? Full screen. Can you make it full screen? Okay. So we'll start off with the latest insulin sensitizers in PCOS. Next slide. So regarding polycystic ovarian syndrome, we have already discussed. Next slide, Bhavya.
Problem in controlling it.
It got stuck. So PCOS, we have already discussed. It's the most common endocrine disorder among women of reproductive age with a prevalence of 6 to 10%. And madam has already discussed the diagnosis based on the Rotterdam criteria. And the next slide. So we'll be talking mainly about insulin resistance and insulin sensitizing drugs. So what is insulin resistance? It is basically a subnormal glucose response to endogenous or exogenous insulin. And insulin resistance is present in 30% of the lean and 70% of the obese PCOS. And defective insulin secretion and function is a basic pathophysiology of PCOS. And high androgens is influenced by the hyperinsulinemia and the insulin resistance. And also high insulin levels have negative effects on ovarian function as well. As a result, the theca cells release large levels of androgens, which in turn cause follicular maturation to be arrested and increases the risk of polycystic ovarian morphology. And also, there are long-term health issues like type 2 diabetes and cardiovascular disease. Next slide. So we'll go on to the strategies to improve insulin resistance. We know first one is a lifestyle modifications. Then the diet and exercise. And then comes the insulin sensitizers. So regarding lifestyle modification, it's a first line treatment. And the next slide. So it has a potential to improve the endocrine and metabolic profile of these patients, the lifestyle modification. But it is challenging because there is always a risk of the regaining of weight. So, next slide. So, pharmacological agents are essential to achieve optimal glycemic control and improve the endocrine disturbance in PCOS. Next slide. So, insulin sensitizers, how do they act? They improve insulin action by increasing the insulin sensitivity, thereby decreasing hyperinsulinemia. It triggers ovulation by reducing insulin resistance and reduce ovarian androgen production and restore normal menstrual cyclicity. So the insulin sensitizers we have are, first one is a good old metformin, then thiazolidine diones, inositols, then the newer ones, dipeptidyl peptidase 4 inhibitors, GLP-1 RAs, that is a glucagon-like peptide 1 receptor agonist, and SGLT2 inhibitors, that is a sodium glucose co-transporter 2 inhibitors. Next slide. So metformin is the oldest and still the most used insulin sensitizers world over. Its action is, it lowers the hepatic glucose production by reducing gluconeogenesis and decreases glycogenolysis. It also increases the peripheral glucose uptake by skeletal muscle and adipose tissue, and also reduces intestinal glucose absorption. So, next slide. It is recommended as a first-line medication for PCOS and impaired glucose tolerance or type 2 diabetes who have not responded to lifestyle modifications. And it is also the second-line therapy in PCOS with menstrual irregularity, where hormonal contraceptives are either contraindicated or not tolerated. Metformin significantly improves BMI, serum lipids, and glucose homeostasis. And it is also found that parallel administration of metformin before and during IVF cycles reduce FSH requirement, improve the quality of embryos, thereby increasing the pregnancy rate. And there have been 2 studies which show that metformin treatment increase the mean number of mature oocytes and cleaved embryos and improve clinical pregnancy rates. Next slide. So metformin should be used as an adjuvant of general lifestyle improvements and not as a replacement therapy for exercise and diet, particularly the adolescent age group. Side effects, usually gastrointestinal side effects, are generally dose dependent and self-limiting. It is we start off at a lower dose with 500 milligram increments every 1 to 2 weeks. And extended release preparation may minimize the side effects. And the suggested maximum daily dose is 2 grams. So we'll go on to the next group, that is the inositols. Inositols act as secondary messengers for insulin, mediating its diverse functions. Myoinositol and D-chiroinositol are the 2 isomers used in the treatment of PCOS. So regarding the D-chiroinositol, it restores insulin sensitivity by curtailing circulating androgens. Myoinositol primarily exerts its benefits at the ovary level, aiding FSH signaling. And both myoinositol and D-chiroinositol reduce LH levels, LH-FSH ratios, and testosterone levels in PCOS. So simultaneous administration of myoinositol and D-chiroinositol in a 40:1 ratio has shown efficacy in restoring ovulation. Myoinositol is a dietary supplement, we know, and it is used for the treatment of obesity and impaired glucose tolerance. And the dose we generally prescribe is 2 grams OD or BD for 8 weeks. But the recent studies which have come in, it is a meta-analysis of 5 trials which have come in June 2024, comparing myoinositol to placebo. There is no significant improvement in body mass index, metabolic or hormonal measurements were observed. We'll go on to the next insulin sensitizer, that is a thiazolidinediones. They increase insulin sensitivity by acting on adipose tissue and muscle to increase the glucose utilization. They decrease glucose production by the liver to a lesser degree, and then they bind to and activate one or more peroxisome proliferator activator receptors, mostly PPAR gamma, which alters the transcription of multiple genes involved in glucose and lipid metabolism. And PPAR gamma is found predominantly in adipose tissue, pancreatic beta cells, vascular endothelium, macrophages, and central nervous system. And PPAR alpha is expressed mostly in liver, heart, skeletal muscle, and vascular walls. Rosiglitazone is a pure PPAR gamma agonist, while pioglitazone exerts some PPAR alpha effects as well. And according to the fatty acid steal hypothesis, the thiazolidinediones promote fatty acid uptake and storage in adipose tissue. It increases adipose tissue mass and spare other insulin-sensitive tissues such as skeletal muscle and liver, and pancreatic beta cells from the harmful metabolic effects of high concentration of free fatty acids. It improves menstrual cycle irregularity, promote ovulation, and reduce androgen levels. And side effects such as weight gain, peripheral edema, and heart failure are there. Next slide. One second. There was a disturbance, sorry. It's rosiglitazone increase the ovulatory frequency and improve hyperandrogenemia even in non-obese women with PCOS with normal insulin sensitivity. When compared with metformin, the effect of rosiglitazone in improving ovulation was lower, whereas the effect of two drugs on hyperandrogenemia was similar. Comparing with the effect of pioglitazone with that of metformin in obese women with PCOS, where both drugs decreased insulin resistance and hyperandrogenemia to the same extent. So coming to the newer drugs, that is the incretin-based therapeutic agents. Incretins are the gut-secreted hormones, including glucose-dependent insulinotropic peptide or the GIP, and glucagon-like peptide 1, GLP-1, that are both secreted in response to meal ingestion, and they enhance glucose-stimulated insulin secretion. And incretin hormones maintain glucose homeostasis by reducing hepatic glucagon release, slowing gastric emptying, and suppressing appetite, thereby helping to control body weight and improve glycemic control. And most of the studies in PCOS have found impaired incretin secretion and activity in overweight or obese individuals, and relatively small studies have reported reduced normal or increased GLP-1 levels in PCOS. So the drugs which come under the incretin mimetics include the DPP-4 inhibitors, that is the dipeptidyl peptidase 4 inhibitors, increase the incretin levels, that is the GLP-1 and GIP, which inhibit glucagon release, which in turn increases insulin secretion, decreases gastric emptying, and decreases blood glucose levels. These are primarily indicated for weight loss, but these sitagliptin, alogliptin, and linagliptin have been studied in PCOS, particularly it's a potential treatment option in metformin intolerant PCOS. Sitagliptin is given at a dose of 100 milligram per day and effectively reduces blood glucose and visceral fat and improve beta cell function and prevent impaired glucose tolerance. Then comes the in thing, that is the GLP-1 RA. That is the glucagon-like peptide 1 receptor agonist or incretin mimetics or GLP-1 analogs. It is an incretin hormone that shares a similar effect with incretin mimetic. Monotherapy or in combination with metformin for managing obesity and insulin resistance associated with polycystic ovary syndrome. And these are primarily indicated for weight loss by stimulating insulin production, suppressing glucagon secretion, delaying gastric emptying, increase the satiety, hunger reduction, decrease energy intake, and regulation of appetite. And it improves insulin resistance without causing hypoglycemia. It has a safe cardiovascular and renal outcome, and a combination of GLP-1 RA and metformin improve menstrual cyclicity, insulin sensitivity, glucose metabolism, and anthropometric measurements. And effect of these medications on the endocrine parameters of PCOS still needs to be discovered, with a considerable gap in the available data. And GLP-1 receptor agonists include the liraglutide, exenatide, and semaglutide, which are as novel therapeutic prospects for PCOS. And liraglutide dose is 1.8 to 3 milligram per day, and semaglutide is also given. And long-acting GLP RAs and once-a-week formulations have demonstrated superior glucose lowering potential with less GI discomfort compared with shorter acting counterparts. And greater weight loss has been shown, particularly at higher doses of semaglutide and dulaglutide. Currently, there are no long-term safety data for the administration of GLP-1 RAs in non-diabetic patients. And the GLP-1 receptor agonist approved for the treatment of adolescent obesity or type 2 diabetes in adolescents include the semaglutide, liraglutide, and exenatide. And the most effective, there are studies of GLP-1 agonist in PCOS, adolescent PCOS as well. And the most effective of these agents include semaglutide. Next slide. Then coming to the SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors. They decrease blood glucose levels by promoting glucosuria and natriuresis and target glucose reabsorption from the proximal tubules of kidneys. Examples include empagliflozin, in comparison with metformin, demonstrated significant improvements in weight loss, BMI, waist to hip ratio, and fat mass reduction. And 50 milligram of licogliflozin administered 3 times daily effectively reduced hyperinsulinemia and hyperandrogenemia in PCOS. And somatostatin analogs. There are studies with somatostatin analogs in PCOS patients. Octreotide, a long-acting somatostatin analog, reduces insulin, LH pulse amplitude, and androgen concentrations in hyperinsulinemic PCOS patients. But daily multiple subcutaneous injections make this procedure inappropriate for long-term treatment. So they have brought up the long-acting somatostatin analog formulation release, that is octreotide, which is injected IM every 28 days. In a selected group of anovulatory PCOS women with abdominal obesity, improved patient compliance. So androgen, GH and IGF-1 concentrations were reduced, while IGF binding protein circulating levels were increased by octreotide LR. And this effect seems to be the consequence of improvement of hyperinsulinemia. Next slide. Then the role of vitamin D and L-carnitine. Vitamin D also contributes to insulin synthesis, enhances insulin receptor expression, and amplifies the insulin response to glucose transport. And studies have indicated that women with PCOS receiving a weekly dose of 20,000 international units of cholecalciferol experienced enhanced carbohydrate metabolism, including a reduction in fasting glucose, triglycerides, and estradiol levels. Coming to L-carnitine. L-carnitine reduces insulin levels and elevates serum adiponectin with a significant improvement in testosterone, FSH, and LH values. Next slide. So, to conclude, the Insulin sensitizers in our armamentarium include the metformin, thiazolidinediones, inositols, dipeptidyl peptidase 4 inhibitors, sodium glucose cotransporter 2 inhibitors, and glucagon-like peptide 1 receptor agonist. Thank you.
Thank you, madam, for that wonderful presentation. So we'll move on to the next session.
Yes.
Dr. Jayalakshmi, madam, are you ready? Still not able to connect. So we'll move on to the next topic.
Suma.
Next topic will be presented by Dr. Suma regarding the lifestyle interventions.
First of all, I would like to thank the Kfog H webinar series team, Kunjumoyedeen sir, Mini madam, the coordinator Mini madam, Sujitra madam, everybody for giving me the second opportunity to present in H series. My topic for today is lifestyle interventions in PCOS. Let me project my slides. Are the slides visible?
Yes, yes, yes.
Okay. So let me start. So we already heard about the introduction regarding the polycystic ovarian syndrome, and my topic for today is lifestyle interventions in PCOS. And I think that is one of the most important treatment modalities when we take PCOS into account. So just brushing on the initial parts, PCOD, we all know it is one of the most common endocrinological disorder in women, and it is one of the most common thing which we encounter in our day-to-day OPD practices. The girls coming up with irregular or absent period, facial hair, upper lip hair, central obesity, and definitely if we leave it untreated, it can cause much problems like infertility or metabolic diseases in future. So definitely we have to address this in serious, and we have to take each and every case into account. And if we take the incidence of polycystic ovarian syndrome or polycystic ovarian disease, every 1 in 5 girls or women in India is getting affected with this syndrome, and 30 to 50% of the common population is having PCOS. So among the PCOS ladies, the risk of glucose intolerance is also very high. Almost 50 to 60% have having glucose intolerance and also associated obesity. So there are a lot of symptoms of PCOD. I'm not going into in detail on that. Just brushing on that regarding the insulin resistance. Because of that, you're getting hyperinsulinemia or diabetes, hyperandrogenism causing acne and hirsutism, hormonal imbalance causing menstrual dysfunction or oligo or anovulation, metabolic syndromes because caused by central obesity, hypertriglyceridemia, and definitely the psychological problems. And I think that is one of the major issues which we adolescent girls, leading to anxiety, depression, and poor self-esteem. So this Endocrinological Society of Clinical Guidelines, they have come out with a clinical guidelines for PCOS, and the overall approach for therapy of PCOS. The main key events or key points are, first, we have to ameliorate the hyperandrogenic features. You have to manage the underlying metabolic abnormalities and reduce the development of risk factors. That is very important. The development of risk factors in future, that is like type 2 diabetes or cardiovascular diseases and the metabolic syndrome. The third thing is we have to prevent irresistant or unopposed estrogens causing endometrial hyperplasias, which can lead to malignancies because of chronic anovulation. We have to prevent that. And definitely for pursuing pregnancy, you can give ovulation induction. So I have put the first 2 points in highlights because these 2 points, the amelioration of hyperandrogenic features and management of the underlying metabolic syndrome, that is taken care of by our lifestyle interventions or lifestyle modifications. So we all know that obesity has got substantial effects on the manifestations of PCOS. When we take all the PCOS girls or ladies into account, almost 35 to 50% of them are obese, and 50% have menstrual irregularities. When we take these obese ladies, the incidence of infertility and menstrual irregularities and more in these ladies or girls with BMI more than 30 kilogram per meter square. So I want to stress on the point that obesity has got a significant role in all the clinical symptoms of polycystic ovarian syndrome. And regarding the PCOS, central obesity, which is itself is a strong indicator as a cause of insulin resistance, that is the abdominal fat accumulation. It worsens all the metabolic and endocrinological profiles in PCOS. And definitely when we get a girl with central obesity, our response to treatment will be a bit slower, or it's very difficult to treat them. The response will be less. The prevalence of this central obesity is actually reaching up to epidemic proportions in many developed countries, especially in adolescents. So this obesity part we have to address and we have to treat before we embark on any of the pharmacological techniques. So what are the lifestyle changes, or what are the lifestyle we have to address on regarding these adolescent girls who are coming to us with all these complaints? When we seek or when we take the detailed history, there will be sedentary lifestyle. I'm sure that when we are during our adolescence or during our childhood, once we come out of the school, we throw our bags to one side and we go out to play. I don't think that practice is there nowadays. It has actually vanished. They'll put their bags aside, they will switch on the mobiles, switch on the iPads, they will do some video games, and along with that they'll keep on munching something. So that is the routine habit nowadays among our adolescent kids. So this sedentary lifestyle, eating habits, associated with that, definitely there will be weight gain. All these things are the components of the lifestyle which we have to address on to intervene and correct before we embark on the pharmacotherapy. And definitely stress and depression is on a rise among our adolescent girls. We are routinely in the newspapers, we are seeing more and more of suicide attempts which are coming up among our adolescent kids. So that is a very important thing, the stress, because as Ashwati madam told, once you give a report of PCOS, that itself is causing a huge mental agony to the kids. So we have to address all these things when we speak to a girl who come up with all these complaints of menstrual irregularities or polycystic ovarian syndrome. So for managing or for lifestyle interventions, for giving this lifestyle interventions to these children with polycystic ovarian syndrome, you have to have a team with you. You have to have a clinician, a dietitian, an exercise specialist, a psychologist, and definitely a counselor. Only with this good team, we'll be able to give them a good lifestyle intervention. And definitely the first line of management in obese and overweight women or girls with polycystic ovarian syndrome is definitely lifestyle interventions. And that include dietary modifications, exercises, and behavioral interventions. So it is very easy to speak. It is very easy to tell you reduce 5 kg weight and you come back next month. But do you think is it that simple? It is really very, very tough thing. And you have to have a keen watch on this adolescents. You have to give them a advice in such a way that they can adapt it and they can reduce their weight as per your advices. You have to give a diet option, exercise option as per each individual, and give them or adjust them like that, so that they'll be motivated so much to reduce their weight and give lifestyle interventions. So this is a very common picture which we used to see in all of our slides in PCOS, junk food versus healthy food. And even us, if you give an option, our hand will definitely go to the left side. So to give that motivation to not to go to the left side of the screen and go to the right side of the screen and pick up the healthy food and make it a habit in their life, that should be counseled very, very repeatedly and properly. That is very important. So regarding the dietary modifications, the portion control is what we have to counsel them ideally. So many of our adolescent girls or women mostly skip their breakfast, and they have tuitions, they have classes, they will have a very small lunch, and they will have a very sumptuous dinner. That is what they practice routinely. So you have to curb that idea and curb that meal pattern, and you have to ask them to spread the calories throughout the day by having 5 to 6 small meals. So you can take a small breakfast in between at 11 a.m. or like that. They can take some fruits or a midtime meal, and again lunch, again a small meal at 4 o'clock or 5 o'clock, then again dinner. So you have to split the calories as 5 to 6 small meals so that the metabolism in the body will not have a deep trough or a huge peak. It will be keeping on humming so that you don't have much of the glycemic levels shooting up. And definitely it will reduce the craving for the food too. That is very common in girls with adolescent PCOS. And what all foods you suggest? What I feel is that if you tell that you take this much calories a day to a girl or a parent with adolescent PCOS, they won't be knowing what is calories, or they won't be knowing what all foods they have to adopt. So you have to counsel them which all foods they have to include in their diet in a way that the child should not feel that she is having some disease. So you can advise foods with low glycemic index, like all the vegetables which are having low glycemic index, whole grains, oats, even sweet corns, all these are having medium to low glycemic index. And again, the white rice and white breads are those having high glycemic index. So you can counsel these girls with who are coming for dietary counseling with the low glycemic index, and definitely proteins. That is very important, because if you ask them to reduce weight, they will keep on dieting like anything, and they are definitely on a growing stage, and they should have proteins in their diet like fish, eggs, pulses, chicken breast. All these things, they can be included in a calculated way or calculated amount, and lots of vegetables, green leafy vegetables. And I would advise including spices, because these spices like turmeric and cinnamon, they have an anti-inflammatory action to help with insulin resistance. So that can be also included. And fruits which are low in fructose and rich in fiber, and those are liked by most of our kids, like grapes, lemon, oranges, pineapples, which are very well available. So you can advise them to take that. And all the berries, even though they're not so available, you can include that too occasionally. So when you give them fruits, select fruits with low fructose and which are rich in fiber. And fats, you can select fats. It is not like you should not take oil, you should not take butter, you should not take, not like that. You can select fats which are good fats, which are rich in unsaturated fatty acids like monounsaturated or polyunsaturated fatty acids. So they can reduce cholesterol, they can stabilize insulin levels and sugars, and definitely reduce the risk of heart disease, can absorb vitamins, fat soluble vitamins like A, D, E, and K. And this healthy fats, you can get those in avocado. It is very well available in our place, and it is very much liked by our kids too. And fishes like salmon, mackerels, even butter in a defined quantity or in a small quantity, it has good fats, and olive oil. All these things you can include in their diet. So an ideal meal, I must say, you have to make it in a very presenting way to these girls so that they feel that they are not having a disease or they are not having a dietary restriction. They are feel that they feel they're like they are getting a new diet. So that should include 20% of the complex carbohydrates, 40% of the proteins, and 40% of the fats. In a balanced way, you can give them, and better avoid or lessen the amount of oils, bake them or grill or broil and give them, and use liquid vegetable oils. And definitely encourage them to have a small brisk walk in the morning, not definitely for 2 hours. I don't think it's practical. At least for 15 to 20 minutes, have a brisk walk. Again, have a breakfast, a meal after 2 hours, and small portion like meal. So that is an ideal meal which we can suggest for this girls who are coming up with polycystic ovarian syndrome. And other minor components like flax seeds, which are very much rich in fiber and omega-3 fatty acids. Then chromium, our routine food items like onions, lettuce, tomatoes, potatoes, all these contain chromium. Chromium definitely promotes weight loss, and it is a component of glucose tolerance factor, which can normalize blood glucose levels. So you can include these vegetables too in their diet on an alternative basis. Then minor elements like zinc and magnesium, which are very well available. Zinc actually has a beneficial effect on acne and obesity. So zinc is very much available in normal things which we give: spinach, cereals, mushrooms, which are liked by everyone, nuts. All these things contain zinc. And magnesium, it most common micronutrient found to be depleted in this insulin resistant people or diabetes people is actually magnesium. So it is very well available in potatoes, salmon, dairy products, almonds. So all these things you can include so that they will get the benefits of this micronutrients. And calcium, that is very important for the bone growth itself, and also for the egg maturation and follicle development in ovaries, and vitamin D, which promote calcium absorption too. So milk and milk products, even if they don't like milk or milk products, then add all the dry fruits, nuts, broccolis, everything into their diet on an alternate basis so that they'll get the advantages of calcium and vitamin D. And B complex too, it has got a very good role in controlling the blood sugar levels, in accelerating the fat metabolism and accelerating the weight loss, and definitely getting good hormonal balance among these women. So these B complex vitamins we can get in all the vegetables we eat in our day-to-day practice, the bananas, the eggs, dairy, everything. So include all these things so that they get the advantages of all the vitamins and the minerals. So the dietary advices which we have to follow should contain carbs. The complex carbs should be less, proteins and fats should be on the higher side, and that too good fats, which can include all these micronutrients. And now coming to the exercise and yoga part, if you tell yoga to an adolescent girl, they will tell, I can't do that. So better you can tell other options like aerobics, Zumba, cycling. All these will be liked by these adolescent girls who are coming up with these symptoms. And definitely the workouts, walking parts, whatever they like, let it be individualistic. Now, whatever they like, let them do it for this much time. And the main goal is to improve the body composition, reduce BMI, improve insulin sensitivity, enhance adipose tissue lipolysis, and definitely improve depression. Because once they get a good body posture itself, their depression and all these things will be decreasing. So getting started with this exercise, it is not like you do exercise for 2 hours a day. It is not at all practical. So let them get started with the help of an accredited exercise physiologist if it is available. And if they are having some chronic diseases, definitely they should have a general practitioner clearance before they embark on exercises. And at least they should start walking for 15 to 20 minutes, 2 to 3 times a week. They can start with that. Or they can do whole body exercises for 15 to 20 minutes, 2 to 3 times a week. And drink plenty of water. Encourage them to drink plenty of water. So they can start with this exercise protocol, and gradually they will like this, and they will keep on increasing the duration and frequency of these exercises, which will be more advantageous to these girls to make it practical. And this is not just like we are telling it. There are so many papers which are come up with evidences showing that this lifestyle interventions and exercises can bring a big, there is a big role for that in the treatment of polycystic ovarian syndrome. And this exercise, according to the paper that is published in the PubMed in 2020, they're showing that exercise as the first line approach in the management of PCOS. In that, they are telling vigorous intensity exercises of at least 120 minutes per week is advised to get maximum effects to improve the cardiometabolic outcomes in the presence and absence of anthropometric measurement. So definitely exercise has a role in improving the symptomatic improvement of these polycystic ovarian syndrome symptoms. And when we come to yoga has got an effect on promoting weight loss, but the main thing is that it relieves stress, because these girls are having high cortisol level because of stress, which can cause an increase in the testosterone and cause androgenic symptoms and weight gain. So indirectly, by decreasing the cortisol level, they are reducing the hyperandrogenic symptoms of these girls. So that is also getting an added advantage with yoga. And definitely it promotes weight loss, increases fertility, enhance blood flow to the vital organs. Everything can be contributed by yoga too. They're just rushing through some of the poses which can improve the blood flow to the pelvic regions. The first thing is a butterfly pose. Second is a cobra pose. The third is bow pose. And as you can see, all these modalities in yoga, it basically try to reduce the abdominal fat content and increase the blood flow to all the vital pelvic organs. And the cat and cow pose, it causes a relaxation of the pelvic organs and improves the blood flow to the ovary. So basic principle is to reduce the central obesity and improve the blood flow to vital organs. And aerobics, again a paper published in 2011 regarding the role of aerobics in polycystic ovarian syndrome. It has shown that it has got a reduction in the body weight of at least 5%, which can lead to significant improvement in menstrual cycle regularity, ovulation, and hyperandrogenism, and 40% higher rates of ovulation when compared to diet restriction. That is very important. Rather than asking them for a gross or a heavy diet restriction, you can ask them to go for aerobics, which has got a 40% higher rate of ovulation. And stress and anxiety, definitely, apart from this yoga and all, you can give behavioral modifications by counseling sessions, yoga trainings. And the key point is that early detection is very, very, very important. You have to understand that the kid is going in for stress, or the kid has some anxiety or some problem, maybe because of some ultrasound reports, maybe because she's thinking that she has the disease. So you have to identify it at first, then only we can treat it. So that is very, very important. So some of the evidences I'll just rush through. The recent Cochrane review, they have also shown that lifestyle interventions, when we compare it with minimal interventions or usual care, it has got a big role in improving secondary reproductive outcomes like free androgen index, testosterone, sex hormone binding globulin, hirsutism. And in turn, it can improve the metabolic outcomes in future too by reducing the incidence of hypercholesterolemia, type 2 diabetes, etc. And this is a paper published by Dr. Neena Malhotra, madam. She has given a very beautiful paper. It is individualistic lifestyle intervention in PCOS women. So when you give individualistic lifestyle intervention in ladies who are coming up for a fertility treatment, the paper is telling that there is a strong rationale for encouraging weight loss following lifestyle modification, because it can improve menstrual symptoms as well as increase the chances of conception in women with PCOS before we go in or embark onto pharmacotherapy. So concluding, there are so many aspects of polycystic ovarian syndrome, and the aspects which are mainly addressed by this lifestyle interventions are: it improves the glucose tolerance, it reduces the hyperandrogenism, it improves the body composition, it definitely reduces the stress and anxiety, and again reduces the symptom, and ultimately it can improve the quality of life of the girl or the women who are coming up with a thought that I am having a grave disease or a chronic disease. So that is why we are celebrating this September as the PCOS Awareness Month, to create more awareness among the girls and the women regarding the syndrome, which is very easily treatable, but it has to be picked up in the right way and has to be intervened in the right way. Thank you.
Thank you, Dr. Suma.
Thank you.
So we'll move on to the next topic. The next topic is by Dr. Jayalakshmi. Over to you, madam.
Good session, Dr. Suma.
Thank you, madam.
I covered almost every point.
Thank you.
The respected Kfog President, Secretary Dr. Subhash Mallya, Sujitra Madam, Chief Guest Dr. Girish, Bhavya, the esteemed faculty members. Sorry for the delay. We had extreme rain here and the Wi-Fi got cut. So is my screen visible? Not so far.
No, madam, not yet.
ma'am.
കാണുന്നുണ്ടോ? ഇല്ല.
എന്തെങ്കിലും ഡിഫിക്കൽട്ടി ഉണ്ടെങ്കിൽ എന്റെ ഫോണിലേക്ക് ഒന്ന് സെൻഡ് ചെയ്തിട്ടോ പവർ പോയിന്റ്. ഞാൻ വേണേ പ്രൊജക്ട്.
Am I audible?
Yes, ma'am.
Yes, you are very
Audible.
clearly audible.
Screen is
but
not visible.
Screen. Okay, I'll just
Share
show.
the screen.
Is it visible?
No.
No,
It's
no,
not
you share the screen, ma'am, first.
Share screen.
Down,
That green button in the
Yes.
center.
And എനിക്കൊന്ന് PPT അയച്ചിട്ടേക്കാവോ? ഫോൺ വാട്സ്ആപ്പ്.
The lower part of your screen, you must be seeing
Share screen.
that share screen.
Now? Yeah, coming.
Yes.
Okay.
Yes,
So
ma'am.
shall I
Yes.
start?
Yes.
Make it slide share.
Slideshow. So in PCOS, the psychological issues can be related to so many factors like hirsutism, acne, alopecia, and menstrual disorders. But the topic that is given to me is this one: menstrual irregularities, puberty, and the psychological issues. So usually the adolescents with PCOS, they can feel anxious and depressed because of the acne. They can lose their self-confidence because of the hair loss. They can feel ashamed because of their physical appearance.
And due to obesity, she can feel inferior to others, especially while buying clothes when there is a comparison between her friends. She can feel worthless in the society. There can be menstrual irregularities, and actually menstrual irregularities are just a part of the entire scenario. And there can be fear of the permanent complications like diabetes, high BP, and cancers. She can have fear about her infertility, and she can be tired about the long course of the treatment of PCOS. She can have fear of taking the OC pills, and then she can have fear about whether she can bear children. Then she can be frustrated about not able to take the favorite foods, which when their peer groups are enjoying this. But because Mini Madam told me just to talk about menstrual irregularity, psychological issues, I'll be sticking to that. So coming to the psychological issues. Sure. So regarding the menstrual irregularities that occur in the Indian adolescent girls, just quoting a study that was done in Mumbai, and there it was found that the most commonest menstrual problems that they have is dysmenorrhea, oligomenorrhea, then menorrhagia. Then PCOS diagnosed only in about 10%. Then these are the other problems that they can have. So now coming to the psychosocial problems of the adolescent girls during menstruation, there can be psychological problems, there can be psychosocial problems. Psychological problems are sleep disturbances, headache before the periods, mood change, irritability, restlessness, stress before periods, unstable mood, and moody before the periods. Psychosocial problems are withdrawal behavior, awareness about the menarche, privacy to change the sanitary pads, and they should be taught to use the sanitary pads. So the psychosocial problems are more common during menstruation in adolescent girls, and the menstrual problems can affect their academic performance, school attendance, and and can be affective and somatic in nature. So the adolescent girls face significant psychosocial problems during the menstruation in terms of access to clean materials, lack of privacy for changing pads, disposal facilities for sanitary napkins, socio-cultural restrictions, less social and psychological and social support, poor knowledge about managing pain during the menses, not availability of the counseling services, and inadequate information on menstruation and its management, and no preparation before menarche, menstrual distress, burden, and the stigma. So previous studies have reported that adolescent girls aged 15 to 19 years felt sick, sad, irritable, missed school during the menstruation. They are unable to concentrate and pay attention during the school hours. And before menstruation, the girls are irritable, depressed, nervous, sad, and during the menstruation, these problems get aggravated. And most girls will be scared at the onset of menarche. Other reactions are worry, sadness, and there are reports of suicidal ideas and death wishes during the premenstrual period. The premenstrual symptoms, depression, irritability, mood swings, and sense of losing control, retention were significantly correlated with students who had suicidal ideas compared to women without suicidal thoughts. And the most common psychological problems reported by adolescents before menstruation is tiredness, anger, headache, irritability, fear, and depression. And few studies reported psychosocial problems such as premenstrual symptoms, sleep disturbances, long bed rest, inability to concentrate on the studies, depression, irritability, headache, malaise, fear, anger, tiredness, foul odor, and anxiety about the foul odor, and disturbance in the daily routine and miss social activity. And the young girls with premenstrual symptoms reported insomnia, nervousness, fatigue, headache, and sleep problems. So many girls were unable to perform the household activities and attend the schools. Dysmenorrhea and menorrhagia increase the risk of school absenteeism among the rural girls. And seeking medical help for the menstrual girls was also very poor among the teenage girls. Dysmenorrhea and menstrual irregularities were also linked with dietary habits like eating junk food, eating less, and premenstrual symptoms were related to lack of physical activities, overweight, eating less, and junk foods. And most studies found that the girls were restricted from the school activity and physical activities such as play, traveling, attending social gatherings, functions, festival, marriages, worship, food restrictions, entering a temple, kitchen, other doing household work, taking a bath, attending school, touching people, and puja materials. And restriction in activity varies from culture and religion. And in some parts of southern Indian villages, girls were even not allowed to enter their own house, and they were asked to sit and take rest in the house and during the menses. And the girls were considered dirty and impure during the periods. And there is an association between education level, activity restriction practice regarding menstruation. So higher depressive symptoms were more in the irregular menstrual cycle. So you can see that when the menses is more irregular, their stress is and depressive symptoms are more. So importance of school mental health education is very important. The school social workers have vital roles in imparting awareness about menstruation and menstrual hygiene management. So also the doctors, if they are coming to us, the awareness programs can be delivered through group work mode. Knowledge, awareness, and dealing with the menstrual problems can be covered under the menstrual health and life skills training. So the following information can be specifically addressed during the program. They should be informed about the age, onset of menarche, the normal duration of menses, menstrual cycle, premenstrual syndrome, common menstrual disorders, body mapping, secondary sexual characteristics, cleaning the genitalia with soap and water, changing the sanitary pad 3 to 4 times a day according to the need, clarifications about the myths and misconceptions about menstruation, and teaching them how to use sanitary pads and proper disposal of the pads. So thank you.
Thank you, madam.
That was super fast and covered all the points.
Mini madam has asked me to finish it fast.
Yeah, you've done it. Everything covered. Most of the issues have been covered.
Shall we move on to the next session?
Okay.
The
It's
next
already
session.
9
Last
o'clock.
session.
Yeah, last session. The next session, the speaker for next session is Dr. Shaijas. So over to you, sir.
Thank you.
Hi, Shaijas.
Hi, Girish. Hi, Girish. Someone else is sharing the screen. If you can stop sharing. Yeah. Okay, I hope my slides are visible and I'm audible.
Yes.
Yes.
Yes, very clear.
Thank you. Thank you so much. First of all, thank you so much to the entire Kfog team led by the vibrant president in Dr. Kunjumuddin, the secretary in Dr. Subhash Malya, as well as the chairperson of the adolescent committee of Kfog, Dr. Mini Balakrishnan, and Dr. Sujitra Sudhi, the state coordinator of this Kfog Edge webinar series. Thank you so much for this wonderful opportunity. Pleasure to have Dr. Neena Malhotra, madam, as well as my dear friend, Dr. Girish, who has done some exemplary work as the adolescent committee chairperson, including the best committee award for the tremendous amount of adolescent health activities that he has done across the country. Pleasure to have all of you here. Pleasure also to have Dr. Vidya Nambiar, the president of Cox, Geeta madam, Omina madam, Lakshmi madam, Kochu Mani madam, all very dear people. And I think
Bharati ma'am.
Yeah, and Bharti madam. Yes, I missed out. Yeah, and Bharti madam, whom I already said hi initially, to have you here, all here. I think the previous lectures, all four of them, Dr. Ashwati, Dr. Jayalakshmi, Dr. Smita, and Dr. Suma, I think generally I would have said have laid a fertile ground for me to take off. But since PCOD is all related to subfertility, I think they have laid a relatively subfertile ground for me to take on from here. And we would talk a little bit on the long-term implications. I think long-term implications are so very important because as you can see, the girl continues to exercise whole throughout her life because that's what she's always been told. I hope you can see that on the screen. So the topic for today would be on long-term implications of PCOD, which would focus on the fertility issues and the metabolic complications as well. Now, life ahead for an adolescent girl with polycystic ovarian disease is something which is quite challenging. Now, in spite of having so many hurdles in front, she's happy and dancing, probably because she's not aware of what lies ahead. We understand that she has a long list of hurdles to cross, which includes menstrual abnormalities to start off with, fertility and related issues. If she happens to cross that hurdle, she becomes pregnant, and then there are related complications. And then, of course, the long-term implications. And none of us are really sure which of those hurdles she's actually will be able to cross, or at which one of those hurdles she would actually tumble and fall down. So the life ahead is going to be really challenging, not just for the clinician, but for the patient as well as people around her supporting her. Now, first of all, a big kudos to all those wonderful gynecologists across the country who, in spite of a very, very busy schedule in their outpatient department, still consider that girl as your own and keep talking to her for hours together in spite of that busy OP schedule. And we do that on a regular basis in an attempt to educate her as well as a family. If not for this, I think the entire society would have been so much scarce with the knowledge about PCOS. So keep continuing that good work that you all do. Now, if you look at the evidence regarding how well this communication is happening regarding PCOS, that's the counseling part in PCOS, other than the medications that we prescribe, the question has always been whether are we actually missing something. Now, you would agree with me that as a girl, people around the girl are only worried about getting her a regular menses. As she grows up, they somehow want to get her married. And after marriage, they somehow want to get her pregnant. Now, the in-laws, the husband, and the other families also involved in the process. If she succeeds in becoming pregnant, people somehow want to make her deliver. And after delivery, just forget about her. And unfortunately, on a personal note, I feel that her midlife is getting totally neglected. I hope you understand the intensity of that situation. Whole throughout the initial growing up years, she has been the focus of the entire family, primarily because she has been the obese one with a lot of skin changes, not so good looking. She has been the one where a menstrual cycle is hard to come by, and she has been the topic of discussion. And once she delivers a baby, she's totally forgotten. And that's where a talk on long-term implications becomes so very important, which is probably the missing link that is happening. And I think the talk about long-term implications should not be restricted to the adolescent girl with PCOS, but it should be continued throughout her reproductive age as well as into her midlife, which is a point when she's totally neglected. Now, the first challenge for any girl would be to deal with the menstrual abnormalities. I think there's been a lot of discussion on that already, so I will not spend much time. But remember that maybe some 15% of these girls could have regular cycles and still have PCOS. So irregular cycles is not a must to have, but majority of them, though numbers and percentages may vary, majority of them will have irregular cycles. And of that, the majority will have infrequent cycles, or what we call as oligomenorrhea. A few have amenorrhea, and even lesser number of people would have polymenorrhea or frequent cycles. So remember this entity, which is one of the earliest hurdles for her to cross. Now, as she gets married, the primary concern revolves around fertility issues. And that becomes a topic of discussion, not just within her family, but in the in-laws family, as well as probably in the society where she lives in. Now, if you are a gynecologist practicing any levels of fertility practice, I hope you all agree with me that anovulation is the major problem. PCOS is the most common cause of anovulatory infertility, which we have been remembering from our undergraduate days. Almost 90 to 95% of anovulatory women seeking infertility treatment have a polycystic ovarian syndrome. But remember that it is not just about the ovaries that is undergoing a dysfunction. We understand that because of anovulation, there is unopposed hyperestrogenism, the lack of progesterone, which gives actually the stabilizing effect for the uterus. This unopposed hyperestrogenism has a significantly bad impact on the uterus, creating a hostile environment for a pregnancy to happen. There is endometrial hyperplastic changes with or without ATPI could be. There could be structural changes like polyps that can happen. So all this makes the interior of the uterus a pretty bad place to have a conception from happening. Now, if she happens to succeed in getting pregnant, there are certain other issues that are involved. Now, the pregnancy-related maternal issues in PCOS would revolve around the risk of miscarriage in the early months. the women with PCOS are almost 3 times more likely to miscarry in the early months of pregnancy when compared to women without PCOS. There is a risk of gestational diabetes, as you know. Because of both maternal and fetal reasons, there is a need for more cesarean deliveries. Women who develop gestational diabetes, as well as their children, they both run a very high risk of developing type 2 diabetes later in life. So, risk of diabetes and PCOD can be linked not just to the mother, but also to the offsprings that they create. Risk of preeclampsia is a definite concern, and as well as the risk of preterm birth. There are other fetal and neonatal issues also that we need to talk about. So it's not just about the mother, but it's about the problems that to the baby too. Now, generally we say they tend to have larger babies, but they could have smaller babies too, especially when there is a super added effect of preeclampsia setting in these women. Because preterm birth is increased, there are more premature babies that are born. These babies are at risk of having a lower ABGAR score at birth. These infants are at higher risk of getting admitted to an NICU, and at a higher risk of dying before, during, or right after birth. So it's a pretty risky state for the baby too. Coming on to the long-term implications, they're very, very important as far as her life ahead is concerned. There is increased risk of diabetes, hypertension, and dyslipidemia. There is increased risk of cardiovascular events, obstructive sleep apnea, non-alcoholic fatty liver disease, cancers, and mental health disorders. We would deal with that a little bit more in detail so that you all get an idea. Now, let's start off with the cardiovascular risk, which appears to be the single most entity which need to be discussed as far as a long-term implication is concerned, because it takes away very important years from her life. Fine. Now, what are the contributing factors? Now, one aspect which has to be considered with utmost importance when we talk about cardiovascular risk in PCOS is dyslipidemia. Now, what is the pattern that is seen? They display a pattern which is characterized by reduced HDL, increased LDL, and increased fasting as well as postprandial triglyceride concentrations. Fine. There is increased VLDL synthesis in the liver. There is a reduction in lipoprotein lipase levels, which is the one which actually breaks down. So there is more hepatic synthesis of VLDL. There is less breakdown. There is also increased hepatic production of ApoB100. And finally, you put all this together, you will find that they end up in hypertriglyceridemia, all happening primarily because of the insulin resistance that is underlying. Add on to that would be the effect of hypertension, which significantly increases the cardiovascular risk in a PCOS woman. Now, percentages and numbers may vary from one study to the other, but I think we should always look at the higher figure so that we can counsel them better and we can communicate them better, because that which creates an alarm in the minds of these girls and women about their life ahead. Now, PCOS women are almost 35 to 37% more likely to develop hypertension than controls. Very importantly, independent of BMI. So even without an obesity factor coming into the picture, PCOS women have an increased risk of developing hypertension. What are the pathways involved? The activation of the renin-angiotensin-aldosterone system, which is implicated in other kinds of hypertension also, sympathoexcitation, and a reduced nitric oxide production. Now, these are the pathways. What are the factors involved? The major factors that are involved, which have been attributed to the etiology of hypertension, would be insulin resistance and consequent hyperinsulinemia and hyperandrogenism. These two are the important factors, which, as you all know, are the key features that you see in a PCOS girl or a woman. Now, women with PCOS have been shown to have a higher prorenin level, a higher renin level, as well as higher aldosterone levels. And all these contribute. Now, if you can extrapolate and think, higher prorenin levels have been attributed to why preeclampsia happens in a PCOS pregnancy more commonly than a woman without a PCOS. Okay, so higher prorenin levels are probably one of the markers in women who tend to develop hypertension in pregnancy when compared to a non-PCOS woman. Fine. As we go on, we look at the other surrogate markers for cardiovascular risk. That's called CIMT, which you all know is carotid intima media thickness, which is an ultrasound measurement We do that even for the general population today. Okay, that's the thickness of the inner layers of the carotid artery. This is used as a surrogate marker of subclinical atherosclerosis. Fine. So we have some good studies, including a meta-analysis of almost 19 studies, which show that there is a significant increase in CIMT in PCOS women when compared to controls. An increase in endothelial dysfunction, myocardial dysfunction, arterial stiffness, and coronary artery calcification are the other 4 surrogate markers in such women suffering from polycystic ovarian syndrome. Endothelial dysfunction, myocardial dysfunction, arterial stiffness, and coronary artery calcification, all put together, increasing the cardiovascular risk and taking away those golden years from the life of a PCOS woman. The other important risk other than the cardiovascular risk is the metabolic risk, okay, which is so very important. One of the primary determinant factors is overweight or obesity. In a meta-analysis of over 100 studies, the pooled prevalence of obesity was found to be as high as 61%. There's always this million-dollar question, right? Does PCOS cause obesity or obesity cause PCOS? What is your take? What is the take of the faculties here? Does PCOS cause obesity or obesity cause PCOS? It's like a chicken came first or the egg came first kind of question. Any takes on this? Because there are some interesting articles and studies that are actually coming out on this, because we have been searching for an answer for quite long, right?
I think it's PCOS first. Dr. Shaijas, PCOS
okay, you think
first.
it's PCOS causing obesity?
Yes.
Okay, fine. Now, let's look at because if I have asked this question, then probably the answer has to be the other way around, right? Otherwise, I wouldn't have asked this question, because I think most of our girls and women who come to our OP would actually tell you, if you ask them, why are you obese? They'll tell you, I have PCOS, that's why I'm obese. Okay. Now, there's a lot of study, including some very good genetic studies, which are bidirectional Mendelian randomization studies, which have consistently demonstrated a causal effect of BMI on PCOS, but not of PCOS on body mass index. And that is why there need to be a lot of stress these days on whether we can prevent weight gain from happening in these girls or in early adulthood, which could even have a preventive role in preventing the emergence of PCOS in these women. I think it's a new entity. Some reasonably good studies have come up, and this could have a big role to play. As Dr. Suma was talking about lifestyle interventions, so we generally talk about PCOS as a disease that is genetically determined, which is there in you from your birth, which manifests during your from the time when you start reaching your menarche or you achieve puberty, and then it stays with you for a lifetime, right? Now, there is another theory that is coming up that when your lifestyle is not good and when you are not able to maintain a normal body mass index, a PCOS kind of picture, a PCOS kind of pathology can emerge even later in life. Okay, so that theory would tell you that if you can prevent weight gain in these girls and in early adulthood, it could actually play a major role in preventing this PCOS from emerging. It's not for every girl, but it's for a subset of PCOS patients where this could play a role. Fine. As we go on, insulin resistance, impaired glucose tolerance, and type 2 diabetes are the other important factors which can increase the metabolic risk in PCOS. Fine. We know that it comes together because PCOS is now well recognized as a metabolic disorder, characterized by reduced insulin sensitivity involving tissue-specific insulin receptors and post-receptor cellular signaling alterations. Now, if you look at some of the systematic reviews, they have found that there is almost a significant reduction, maybe almost 25 to 30% reduction in insulin sensitivity in these women with PCOS. There is a 3-fold increased risk of developing impaired glucose tolerance if you have PCOS. There is almost 4.4 to 4.7-fold increased risk of developing type 2 diabetes. There is a 2-fold increased risk of developing metabolic syndrome. Now, continuing with the metabolic risk, there are 2 less discussed entities. And those are, one is a non-alcoholic fatty liver disease. It's also called metabolic dysfunction associated fatty liver disease, MAFLD. The other is NAFLD, and it can also be called as MAFLD. So we understand that the metabolic risk is involved. Now, what happens here? Insulin resistance is there that increases the lipolysis of the adipose tissue. It leads to an increased fatty acid efflux to the liver, and consequently, the entire fat gets deposited in the liver, the entity called hepatic steatosis. Okay, so always remember this entity called non-alcoholic fatty liver disease. We are not talking much about that to our PCOS girls and women. I think we need to do that. And the other entity is called obstructive sleep apnea and sleep disturbances. This is characterized by intermittent upper airway obstruction. There's a lot of snoring that happens during sleep and consequent hypoxia that results. And if you look at incidence, though numbers may vary, as I said, almost 35% prevalence of obstructive sleep apnea in a woman with a PCOS. Very important. Coming on to the cancer risk, which is so very important. Most important is endometrial cancer. I told you it's not a hostile environment for a pregnancy to happen, isn't it? Because of all the unopposed hyperestrogenism that sets in. Fine. Now, if you look at evidence, it will tell you that there is chronic anovulation, there is prolonged unopposed estrogen that promotes endometrial hyperplasia, especially the ones with atypia moving on to cancer. And even in young women with PCOS, there's almost a 2.8-fold increased risk. So if you find an abnormal appearing endometrium, either on your imaging or while doing a hysteroscopy for a fertility workup in a relatively young woman with anovulatory cycles and PCOD, do not forget about that risk of an atypical endometrial hyperplasia or a cancer, even if she's young. Okay, here her age doesn't give her protection, though endometrial cancer is generally a disease of perimenopausal or postmenopausal women. Ovarian cancer. Now, the only happy news in the entire presentation is the protection that PCOS can give against ovarian cancer. You have that evidence from the Ovarian Cancer Association Consortium, which have reported a reduced risk of invasive ovarian cancer. But this reduced risk comes at the cost of less ovulations. So that will cause infertility and other kinds of problems, isn't it? So less number of ovulations, so less damage repair mechanisms, so less incidence of a mutagenic change that can happen during the repair mechanism, which is the theory behind the development of an epithelial ovarian cancer, is the thing that is coming into the picture. And hyperandrogenism that is there in these women also gives some amount of protection against ovarian cancer. The only happy news there. Now, if you look at breast cancer, we know that it could run at an increased risk, but most of that increased risk is related to estrogen receptor positive cancers and not for estrogen receptor negative breast cancers. Now comes the mental health risk in PCOS. I think Jayalakshmi Madam has already thrown some light on that. I'll just touch upon this. Depression and anxiety are probably very important issues. Why does it happen? It happens because of obesity. It happens because of skin changes, which makes her look not so desirable. There's a resulting negative body image that happens. Add on to that is her inability to conceive when she wants. So everything could just add on. The other important disorders which are getting missed out as far as mental health risk is concerned is eating disorders. The risk appears to be more for bulimia nervosa as well as binge eating disorders. And the risk is not increased for anorexia nervosa. Okay, so that is something which you can very specifically remember. The other mental health disorders which are involved are, there is an increased risk for bipolar disorder, personality disorders, tics, some part of the autistic spectrum disorder, schizophrenia. All these were confirmed to be at an increased risk in PCOS women when compared to women without PCOS. Continuing, there could be some cognition-related disorders. These women could have some very subtle defect if in a detailed study, subtle deficit in reaction time, in word recognition tasks, verbal tasks, manual dexterity is those acts where you need to utilize your hand skills to perform an act with some skillful movements, skillful subtle movements, okay? Visuospatial memory, everything seems to be subtly affected. So that's something which you can look at. And the other entity, which is coming up in a big way, and we're talking about it more these days, it's called idiopathic intracranial hypertension. Why does that happen? when there is androgens too much in excess, no, it has got a potential to increase CSF secretion. And that's why there's an idiopathic intracranial hypertension, which tends to happen in PCOS women at a slightly higher risk when compared to a non-PCOS women. Now, what are the take-home messages from this lecture? One is that we all know that we need to, as you talk to her, don't restrict yourself to short-term goals, because those are about achieving a menstrual cyclical pattern, fertility and related issues, pregnancy and related complications. Making her and her parents understand the long-term implications can actually go a long way. And those long-term implications would include cardiovascular health, metabolic health, cancers, and mental health. Remember that it is not PCOS that is entirely responsible for obesity. If you can actually prevent a weight gain from happening in early adulthood, you could actually prevent the emergence of such a deadly disorder like PCOS, which can actually take away a lot of golden years from her life. Now, that was the lady who was ignorant and was dancing happily because she did not know about the difficulty of the hurdles that she had to cross. Now, if you can educate her well, if you can talk to her about the long-term implications that are involved, I think she would be crossing the hurdle as graciously as this lady in the picture. Thank you so much on that note. It's been a pleasure to be here today.
Thank you very much, Rajesh. As usual, you batted a lot, and probably you have enlightened, every aspect of adolescent PCOS, especially the topics or the angles which are not usually discussed on such kind of diets. The only take-home message from my side as an expert, I would like to request every obstetrician and gynecologist that take this adolescent PCOS very seriously, because in routine practice, we are very keen about the infertility or the geriatric problem or gynecological problem in the old ladies. Even the white discharge and UTI are considered very seriously in the patients, but adolescent PCOS is taken very lightly. And specifically, the doctors are not stressing upon the involvement of the whole family in the lifestyle management of that girl. For example, the doctors, they are, advising everything to that girl very lightly, that you should reduce the weight, you should do that, and you should do this, you can do this, etc. But unless and until the whole family is involved in that process, it's almost impossible for that girl to accept or to do all these things and to reduce the weight. And as you said very rightly, that obesity is the thing we should be taking care from the childhood, and the whole family, the lifestyle of the whole family should be changed and should be convinced very seriously. And the long-term follow-up is very important, because in routine practice, what we are observing, most of the doctors, because they are very busy, they are prescribing the OCPs and all the medications for the regularity of the menstruation. Even they are prescribing the metformin, myoinositol, everything to the girl. They are talking very less to the family and to that girl. That girl is getting her regular menstrual cycle for 3 or 4 months till she's on that medication. So she's under wrong impression that she's getting corrected and she's okay now. But as soon as she is off the medicine after 3 or 4 months, and she is not taking care of her weight or lifestyle management, again she is going to the same disease and same symptoms, and the family is getting worried about. And that's why the family and the girl should be convinced very powerfully. In my routine practice, what I am trying to convince the patient and the family, that my drugs will be beneficial only up to 30 to 40%. But the weightage of the lifestyle management is almost 50 to 60% in your management. And I'm warning you that if you're not giving attention to the lifestyle management very seriously, you are going to come on the symptomatology after the finishing of my medicine. So if you are ready to accept this lifestyle management practices, then only start these medications, otherwise leave the treatment of PCOS. Probably this is the only take-home message from my side. And please try to convince the mother especially to be the partner of that girl in the lifestyle management in every aspect, right from avoiding the samosas and kachoris and the morning walk and exercise and everything. Otherwise, it is almost impossible for that girl to do all these practices. Thank you.
Bharati ma'am.
very, very informative and very entertaining talk to. And I rightly agree with Dr. Girish Mane that we have to speak to them with the family and talk to them and tell them that it is nutrition rather than telling them diet. I would put it as nutrition. And we have to tell the parents to change their cooking habits, because in many issues, it is the parents who are working. They don't have time to make traditional food. So they are putting on the table any fast foods or junk foods or whatever, just to get away with their problem of cooking. And the other thing is they come back and sit with their mobile phone. They come back and sit with their laptop. And the children are also, the whole family is sitting with mobiles and laptops. So that part of the lifestyle should go. And as rightly said by Dr. Suma, we hardly see any family going out and playing in the park or going out and having a walk together nowadays. We don't see. So this lifestyle is what, even in my practice, I do deal with a lot of PCOS children, and I spend time with them. And I try to become their friend rather than just pointing fingers at them. I try to tell them, and I usually tell the mother, see, the mother complains that they don't eat vegetables, they don't do this, they always have a negative thing. So I immediately turn over the leaf to the mother and say, you are not accompanying your daughter to the park. You are not allowing her to cook.
Bharti madam, you got muted.
Muted. Net boyo.
Ma'am, you are mute.
Muted, madam. Bharti madam.
Net boyo.
No, she's just muted. Bharti madam, can you unmute yourself?
Not possible.
Probably she's not able to hear also.
No, she is responding. I think she's able to hear, I think.
Yeah.
Yeah, I'm so sorry. I just didn't know where the call was coming from. And and the other thing is, we have to tell them that praise them even if they lose 200 grams of weight and come back. Be positive. I mean, the adolescents like to be praised that you're looking beautiful. It's so good. You've just lost 200 grams of weight. And then I generally give them a chart which they point out for 2 weeks what are all the exercises they have done and what is the food they have had for breakfast, lunch, dinner, whatever. So when we come back and I sit with them with that chart, and then I keep appreciating them and say, good, you have not had white rice today. You've not had too much any junk food today. You've done your exercises. I think this type of positive attitude by the consultants, and we should either have a separate confined clinic where we can spend time after our busy outpatient and talk to them about these positive goals, and that makes them feel good. So when they have that feel good, they want to come back to us and they'll say, yes, doctor, we will follow what you need to. I think that's my take home message. Let us spend more time talking to them about nutrition and their lifestyle. I generally tell them, if you can't do exercises, just put on some music and dance like Dr. Shai just for 15 minutes. That gives you a good exercise. I think that's a very good calorie burner. Just dancing for three songs. Don't you say? Do you agree with me, Shaijas?
Madam, Dr. Shaijas has so many aspects. You know, he's a badminton player. He's running out India for the semis, as well as he is a dancer. I mean, he can never have PCOS.
Yes.
His daughter will not have PCOS.
The other, if there is time, the only one point which I just wanted to add on was, there is a lot of research that is happening on. I think it was a wonderful lecture from Dr. Suma about the lifestyle interventions and the diet. Okay, and Bharti Madam was talking about the importance of nutrition. Now there is a lot of concept being rewritten now about diet, which is telling us that calories is probably not the main thing that we need to focus from now on. Okay, calorie basically mean that. In very simple words, if you take a food item, if you keep it in a box and then keep it under an aquarium and blast that material, the amount of temperature rise that happens in that water level, which is above that food substance, is basically calories. Okay, So it seems that the importance of calories and concentrating only on those numbers, those 2,200 and 2,300, are probably slowly losing its importance. And the thing that we should be focusing from now on would most probably be on the number of glucose spikes that happen throughout the day because of the food item that we are eating. Okay, so there is a lot of studies that are coming up, very good quality studies which are talking about glucose spikes. That means if you can reduce the number of glucose spikes throughout your day, you will tend to lose weight as well as you will remain metabolically normal. So that's where there are a lot of new researches coming up, and I think we will have to wait for some more time for some solid things to happen. Now, so those are some emerging concepts that are coming up about diet, away from calories and concentrating more on glucose spikes, on not just glycemic index, but on glucose spikes and how we can reduce the intensity of those glucose spikes by arranging your diet well. Mean to say, when you start your diet, a fruit juice or a cup of coffee should never be the first thing to start off with.
Yes.
It should always be the last thing to end that diet with. Okay, some subtle changes like that, which can reduce the intensity of the glucose spike, which can happen from your diet. And that can have a lot of meaning to make you more metabolically healthy. Not just applicable to PCOS, but applicable to women and men with non-PCOS pathologies also. Thank
And
you.
even the trainers, physical trainers used to say, start with the protein first so that you won't feel so much hungry and you can carry a long time without food until 2 p.m., 3 p.m. and out. So that also adds to the less insulin spikes in the
Yeah.
That is what you told just now must be against the concept of what Dr. Suma was telling, because she told that you should distribute your the whole day meal in frequent meals. I mean, small 4 to 5 meals, no?
But that,
So probably that
doesn't,
will create more than, I mean, more spikes, glucose spikes.
no,
Yeah,
splitting the
but, no,
food will
yeah,
continuous
but
level of sugar will
basically,
be there.
I think basically it's a very different theory from what we all have been following and what we all have been conventionally believing in. I think we will still have to give it a little bit more time to see how much are the long-term effect, how much are the long-term impact of such kind of diets on the long-term health of the man and the woman. But it's definitely a concept which is worth looking at. And they are even talking about some few things in our diet which can actually be added, something like a vinegar. If you drink a glass of water with a little bit of apple cider vinegar, it tends to reduce the intensity or the amount of the glucose spike that can happen because from a diet and all that. So these are emerging concepts. These are not what you say fully established to be talked worldwide. But I think emerging concepts have to be kept in mind, because maybe 5 years later in a Kfog Edge webinar, we will not be talking about calories at all.
But can it be like that if you are taking it continuously, the spikes, amplitude of the spikes will be less. So that means there will be an even level of sugar that is being maintained, and the high rise or high spikes will be less.
That is what they are telling. Like, we should maintain a basic metabolic rate, and the troughs and peaks should be avoided so that the insulin resistance can be taken into. That is why they are coming up with this modality of diet.
Yeah. Yeah, I think the major point that they're telling is because Indian diets tend to start with the bed coffee.
Yes.
And that if you have with the sugar, then you're totally spoiling your entire plan.
Correct.
And then all our so-called good platter of breakfast generally have a fruit juice to start with, which is probably the worst in that actually. Even if it is a fruit juice,
fruits without sugar.
Even when it is a fruit juice, it still spoils the entire breakfast.
Guys, in our childhood, we used to see 1 or 2 obese boys or girls in a whole school. Do you agree with me? Correct. But now the scenario is totally different.
Yes.
Probably the students away from the ground and near to the junk food is the only reason for the whole scene. Only these 2 things should be taken care, and probably, I mean, we will get the best results.
True.
Yes, sir.
I still have my own doubts whether family going to the park is going to make a difference or not when there is so much of resistant adipose tissue. I think what they actually require is some very significant amount of physical activity to lose that little bit of weight, actually speaking. So there are a lot of men and women going for a walk, 3 or 4 of them together, gossiping, holding hands with each other and considering that they are doing a walk. But that's only good for mental health.
No. Instead, they will sit in the park and they will enjoy the junk food simultaneously in the park, other than their home. So friends should go on the ground. Friends should go on the ground. Playground. So thank you very much. I think
thank you everybody. Thank you everybody for staying back so late.
Messages.
Yeah.
Thank you very much for inviting me, Mini Madam. Thank you very much.
Thank you, sir. Thank you, sir.
All of you. Thank you very much.
Is there any
Thank
vote
you,
of thanks, Bhavya?
Thank you,
Yes,
all the
Subhash.
faculties, for being
Subhash.
with us.
Subhash is there? Subhash?
Subhash
No?
is not there, I think.
Okay, Bhavya can do that.
Yeah.
In the name of Kfog and the webinar series, I would like to thank our chief guest, Dr. Neena Malhotra, and Dr. Girish and Dr. Bharati for being with us. And I would like to thank all the presidents of 5 societies who took part in the webinar. I would personally like to thank all the speakers for the wonderful delivering of the lectures. And thank you, Mini Madam and Sujitra Madam, for this opportunity. Thank you all. Have a wonderful night.
And let us come with the goal chart also, something which can be given to the students and parents, so that after 6 months we can assess. Let us try to prepare that also.
Okay.
Thank you all.
Good night, everyone.
From the
Good night,
Adolescent
everyone.
Society.
Good night.
Night.
Thank
Bye-bye.
you,
Take
Girish
care
sir.
of
And
Guys, are you coming to Patna in adolescent conference?
Girish, which one?
Patna conference, adolescent conference, July 27, 28th.
Okay. What was the date?
27th and 28th of July.
Oh, 27, 28. I think I'll just try to make it. I'm not sure yet, but I'll just look at
No
it.
issue.
Okay.
See you.
See you soon.
So all the best for the coming election, sir.
Is it the annual conference, sir? Is it the annual conference?
Annual conference is in Mumbai, no? In January.
Yeah. Okay, then take care, everyone.
Good night.
Good night.
Good night.
Bye-bye.
Bye. Thank you, Bhavya, too. Thank you, Bhavya. Well done.